What I'm going to do is give you an overview of the portrait, how we came about the information, and just go over it briefly. Before I do that, I want to point out that if you go to the TI website, you'll see on the left-hand side a link to our portrait subpage. And in there, there's information on all the other portraits we have. So you can share that with your colleagues if they haven't registered for portrait. And once you sign into your portrait, you will be seeing something like this. What you'll be receiving in your portrait is something like this. And it basically is a 1 to 2 page summary of your prescribing of zopiclone and trazodone, and it's comparing your prescribing to other prescribers in BC. When you received the portrait, you would have also received access to the therapeutics letter, which is a much more comprehensive document that outlines the evidence that we looked for and found and interpreted that informed the portrait. So moving on to my slides. So to begin, I just show you my declaration. I get paid by Fraser Health. I'm a pharmacist in the Fraser Health Hospital System, and I get paid by UBC. Okay, so what questions did we ask when we started with this portrait? Basically, our research question was, do people sleep better when they take zopiclone or trazodone? As simple as that. And if they do, how likely is it that a patient would feel better in terms of their insomnia if they're on one of those two drugs? And then if there was evidence that zopiclone or trazodone helped people with insomnia, what is the lowest effective dose? And then we also explored harms and how likely was it that a patient taking one of these medications would experience harm, and specifically what harm. And then we tried to offer what we call strategic prescribing or optimal prescribing and deprescribing tips for those prescribers who either are considering starting new patients or have existing patients on one of these two medications. And where do we look for evidence? We look for the most up-to-date systematic reviews to identify randomized controlled trials of either zopiclone or trazodone. We conducted our own search for RCTs outside of existing systematic reviews. We looked within product monographs in Canada and in other countries. We also looked for unpublished information through regulatory reports that were available either through Health Canada or the US Food and Drugs Administration. And we looked at the Canadian Agency for Drugs and Technologies in Health reviews. Now you may know that organization as Canada's Drug Agency, but it's essentially the same people and process. And then once we found those randomized controlled trials, we did our own critical appraisal of each of those and made our own inferences based on the best available evidence that we could find. This is a typical TI process. So let's start with zopiclone. When we looked at the last year's data, there were about 132,000 people that had at least one prescription for zopiclone. Oh, there's a typo in there. I see. And then what we noted when we looked at the evidence was the ceiling dose for zopiclone is different for elderly patients versus non-elderly patients. And by ceiling dose, what we mean is when we looked at evidence of a dose response above this dose, there was no more added efficacy or improvements in sleep to be had, and there is likely to be an increased risk of harm. So logically, it would not make sense to exceed the ceiling dose for patients for the majority of patients. Obviously, there may be one or two or a few people that are outliers and may experience more benefit above these ceiling doses, but on average, these are the ceiling doses. The problem in BC when we looked at prescribing is that most elderly people use more than the ceiling dose, so more than 5 milligrams per daily. So 60% of the prescriptions for the elderly population in BC exceed 5 milligrams per day. And of all first prescriptions, 75% of them exceeded what we think is a reasonable, logical, evidence-informed starting dose. So below 3.75 milligrams, there appears to be no separation from placebo, but in our look at the evidence, it's reasonable to start at 3.75 milligrams. It says that in the product monograph, and then titrate to effect without exceeding the ceiling dose. But 75% of first prescriptions in BC exceed that starting dose. We noticed a trend that zopiclone use is declining overall, and that's probably because people are using other drugs like mirtazapine, quetiapine, or lemborexant. Let's get into the dosing. So what we consider optimal dosing, as I've already said, start with 3.75 milligrams and titrate to an effect. And I'll talk about this earlier, but titrating to effect based on about a 1 week therapeutic trial is absolutely rational and logical based on the kinetics of the drug. Long therapeutic trials are unnecessary. In the non-elderly, there is no benefit to be obtained above 7.5 milligrams in the people that feel better on Zopiclone. So not everyone feels better on Zopiclone, but for those that do, going above 7.5 milligrams doesn't add anything. And that ceiling dose for the elderly is 5 milligrams per day. Unique problems with Zopiclone that we noted, there have been reports of what they call interdose withdrawal symptoms, because even though it has a half-life of about 12 hours, which depending on how you look at it can be long or short, when the dose you took the night before wears off, some people can experience this short-term or acute withdrawal that may look like anxiety. So one of the things to be careful of is identify that if patients are complaining of restlessness or anxiety during the day, it may be an interdose withdrawal phenomenon from Zopiclone, not new anxiety. So be relatively cautious about considering this as new anxiety needing new drug therapy. There's also reports of next day impairment that can last up to 12 hours with Zopiclone. So for example, a 9 p.m. dose may still have an impairing effect at 9 a.m. the next day. So if that person were to be getting in their car at 7:30 a.m. and driving, that might be a problem. And the impairment has been equated to what is the equivalent of exceeding the legal limit of blood alcohol that you're allowed to have in your system when you're operating a motor vehicle, for example. What is Zopiclone likely to do? So to summarize, about 1 in 12 people that try Zopiclone for insomnia say they sleep better, but 11 out of 12 won't feel better. About 1 in 8 people who take Zopiclone experience some form of harm, whether that be minor or major, and that includes things like falls, vehicle accidents, or next day impairment. For those that feel better, on average, the effect in clinical trials, and remember, these are carefully selected patients that are carefully monitored, usually with polysomnography. So these are the best estimates in the patients most likely to benefit from these drugs. And on average, patients that do feel better say that they feel better in terms of falling asleep about 12 minutes faster, and their sleep lasts about half an hour longer. So for some people, that might be a meaningful improvement in sleep. They'll take anything that they can get. But for other people, those numbers may not be worth taking a drug every day and experiencing the side effects. It's just not worth it for them. So it's important to ask your patients if they do feel an effect, is it worth it for them? And like I said before, based on the kinetics of the drug, prolonged therapeutic trials or a month's prescription and then asking the patient, how do you feel about your sleep is probably way too long. Most patients should know if they're feeling the effect and if they think it's worth it within a week. So the same information for trazodone. It's an off-label indication to use trazodone for insomnia, so we do not recommend it. The evidence for trazodone in primary insomnia is weak and sparse. Despite that, about 120,000 people in BC take trazodone. Our evidence review suggests that the ceiling dose is 50 milligrams, and the problem in BC is 40% of patients taking trazodone exceed what we think is the ceiling dose. And another problem is that when we look at our trend lines, the use of trazodone in BC is increasing. So the optimal dose, if you must, we suggest starting at 12.5 milligrams to 25 milligrams. So based on the literature in studies, below 12.5 milligrams, there was no separation from placebo. It started to separate at about 12.5 milligrams, and there was no added benefit above 50. And in the best trial that we could see, trazodone improved sleep better than placebo in the first week, and then by the second week, it started to wane and approach the effect that was seen with placebo. So there's not a ton of evidence to support this, but there is one randomized controlled trial that suggests that even though initially a patient might feel improvements in sleep, after a couple of weeks, that might start to decrease. In terms of harm, trazodone is known to increase the risk of falls, short-term memory impairment, and induced verbal learning deficits. So it's not innocuous. And what will trazodone do? About 1 in 12 people sleep better. And as I said, for some people, that effect might only last about 2 weeks. And so if 1 in 12 feel better, obviously 11 out of 12 will try trazodone and not feel better in terms of their insomnia. About the same number of people will experience some harm. So 1 out of 12 people will experience falls or cognitive dysfunction or those verbal learning deficits, maybe next day impairment. But the evidence for harm in trazodone is also very weak. So not many trials reported harm in a way that we could quantify it like we did for zopiclone. There's insufficient evidence to quantify the effect of trazodone on sleep metrics. So for example, those minutes that I quoted for zopiclone, we don't feel confident in the data from clinical trials to be able to say how many minutes people sleep longer or fall asleep faster. So patients will know once they start trazodone within a week if they feel any better or feel an effect at all. And then it's probably a reasonable time to ask them, do they think it's worth it? Some general prescribing tips for new starts. 1 week is a reasonable therapeutic trial when starting, and if no better after 1 week, then stop. If some patients say, well, what if I tried a higher dose? Our suggestion is that's reasonable to try, but do not exceed the ceiling dose and do not try it for more than a week before reassessing if the higher dose made a difference. In terms of patients that are already on these drugs and maybe above the ceiling dose or considering using a lower dose because they're experiencing harm or they just want to try to get away with something lower. Based on the Maudsley deprescribing textbook, it says that about 2/3 of people can tolerate a 1/4 tab reduction weekly, and a smaller group of people may require a slower taper over 4 to 6 weeks. So it's best to gauge it patient by patient. And immediately after stopping or reducing the dose, patients may notice symptoms of withdrawal that mimic some of the things that trouble them about having insomnia, such as irritability, restlessness, confusion, or anxiety. So reassure the patients that the initial response to tapering or stopping will be you might feel worse, but there's ways to mitigate that, and that should dissipate over time. But I think it's important to notify people that this might happen so they don't get concerned and then just start back on what they were doing before. So some important information. Initially, when I was trained as a pharmacist, I thought if someone's going to experience an adverse event, it's going to happen soon after they start. But in the literature, that doesn't appear to be the case. So people that initially tolerate something may later end up finding that they experience adverse events that are associated with the drug. So keep your eyes and ears open several months after initiation. Look for prescribing cascades in both directions. So for example, are the patients on medications that may be triggering or inducing insomnia, hence the request for something to help with insomnia? Or have they already been using zopiclone or trazodone and that's in causing that interdose withdrawal that mimics as anxiety, uh, hence requests for something to help with anxiety? And then there's some excellent resources above and beyond the TI, like the Provincial Academic Detailing Service. There's a screenshot of their website up in the top right corner. And then My Sleep Well, which you're going to get the expert on the topic and that resource speaking to you soon. And then we're very open to hearing what you think about your sleep med portrait or the portrait program. So there are some questions embedded in the evaluation for this webinar, but please reach out to us at any time if you have any suggestions or questions for us about your portrait. So I'm going to stop there and hand it over to David to share his screen.
So I'm a professor with Dalhousie University. So I'm on the opposite coast, the Atlantic coast in Halifax, Nova Scotia. Just as an anecdote, I am a graduate of UBC from several decades ago. So did my graduate PharmD work there. And I've been working in psychiatry in the area of mental health psychopharmacology services to individuals who live with mental illness for a little over 30 years now. I'm the director of community psychiatry research here with the Department of Psychiatry. I'm a member of the Canadian Sleep Research Consortium, which is a CIHR funded grant I'm also part of what we call ourselves the Dream Team, which is a multidisciplinary knowledge translation program at a Queen's University. And I'm also part of the Older Adult Insomnia Collaborative, which is associated with something called Jerry Medrisk, a consultation service in Ontario. So that's kind of quick background about me. But probably the most important thing for me to say is I'm a co-developer. We developed Sleepwell about 10 years ago. So I'm going to feature Sleepwell in today's update, just to give you some resources that are complementary to what we're talking about today. So let me just jump in and say, first and foremost, this is my generic disclosure slide. I don't have any affiliations with pharmaceutical or other commercial entities, and my funding comes through grants. And when I mention Sleepwell, it's not a company. Sometimes people think it's a company. It's really a research and knowledge mobilization program that we have here at Dalhousie University. So that's what I'm going to be talking about. So let's go back a little bit and put the umbrella a little bit higher than pharmaceuticals for the management of insomnia and look at what's first line therapy and second line therapy. And everybody agrees internationally around the world, first line therapy for chronic insomnia is not pharmaceuticals. It is something called cognitive behavioral therapy for insomnia. So just some examples are written there in front of you. The American College of Physicians says ACP recommends that all adult patients receive CBTI, cognitive behavioral therapy for insomnia, as the initial treatment for chronic insomnia disorder. And you meet criteria for chronic insomnia disorder or insomnia disorder if you're using the DSM-5 criteria on your 91st day of having insomnia. So you have to have it for 3 months. And many people have had it, obviously, for much longer than that. But hardly any of them have actually had treatment with CBTI, and we're trying to change that overall. Europeans basically say the exact same things, and there's several other guidelines that have come out to say quite similar information overall. So I'm not going to have time to really talk about what it is, but I'm hoping that I will lead you to where you can find out more, and more importantly, where you can lead your patients to find out more about the more effective and safer treatment for insomnia, especially for short-term use to get long-term gains. So CBTI is a multi-component intervention. The components themselves have been studied for decades independently and have been sort of grouped together. So patients can use different individual components and have improvements in their sleep, and they don't have to use all components. And when you break down the components, they are composed of behavioral components, cognitive components, and education components. Sleep hygiene is not listed here because for chronic insomnia, sleep hygiene is really considered to be an ineffective intervention. It's useful for acute or short-term insomnia, and that's where its utility ends, is short-term insomnia. If we're recommending sleep hygiene in somebody who's had insomnia for months or years, we're really not helping them. We really need to change our approach and introduce them to different techniques, such as stimulus control techniques, time in bed restriction techniques, or sleep compression therapy. And sometimes cognitive restructuring is necessary. The top two are really considered the most effective, the largest effect size. Relaxation techniques can also be helpful, but in and of themselves, they may not be enough for managing chronic insomnia. I'm sure you're all aware and have seen this over and over again, where Choosing Wisely and other campaigns over the years have said to reduce the use of sedative hypnotics, especially in older adults, whether it's being used for insomnia, agitation, or delirium. And when you look at the most recently published work by Wade Thompson in Vancouver, showing that the overall use of sedatives across British Columbia is going down. So the numbers are looking quite good in British Columbia for all ages, going down 51 out of 1,000 down to 45 over about 10 years. And for older adults, 123 down to about 99. But I've shown this information just to get a little bit more detailed so you can see that what's really going down is Z drugs and BZDs, which are the benzodiazepines. What's not going down, it's actually going up, are alternatives. So Aaron talked about trazodone and quetiapine and potentially mirtazapine. And what you probably will notice that's not there is the actively marketed class of medications, the DORAs, so daridorexant and lemborexant, and I'm sure you've come across some promotional materials or have had interactions with people about those. And so they're not represented here. So the numbers are actually going up for the medications that have not been promoted in the sense of they're dangerous and they're concerning, like the Z drugs and the benzodiazepines. And we're starting to see a bit of a, what I call a whack-a-mole approach, where we're pushing down some of the sedatives, but others are popping up. And overall, that's a concern when we think about long-term use of these medications as being second-line therapy and much less effective and less safe overall. So Aaron mentioned this, and I'm just going to repeat it. What's the benefits that you get from sedative hypnotics? So across the classes, you've got the DORAs and you've got Z drugs and antihistamines, and you've even got old tricyclics that have resurfaced, like doxepin in a small dose for the treatment of insomnia. Um, when you look at their overall effectiveness, the Z drugs actually are pretty good examples because they're as good, if not a little bit better than in some of the systematic reviews. So an 8 to 16 minute advantage for getting to sleep faster compared to the placebo group, and staying asleep longer, 5 to 23 minutes with the Z drugs. So that's what you're getting with them in short-term trials. You're also getting this. You're getting an increased relative risk for injurious falls, fractures, hip fractures included. Most people are not aware of their effect on cellular immunity. And so we see increased complications with flu-related pneumonia and death, as well as hospitalizations associated with COVID, if you're currently taking a Z drug or benzodiazepines. The biggest concern for older adults related to these medications, and this is what I do talk with my older patients about, is cognitive impairment with the medications. And that seems to be something that makes them definitely rethink their long-term use of these medications and think about alternatives. And Aaron talked about the data that's come out of the Netherlands that is great, really well-designed studies that show that if you're giving zopiclone and the patient gets up the next day, drives 10, 11 hours later, their level of impairment is on par with a blood alcohol content of about 0.05 to 0.08, depending on which of the studies you're looking at. And again, most people are not aware of that kind of thing. And then withdrawal is associated with a rebound and confirmation that the person is thinking, I need my sleeping pill because when I try to come off of it, my sleep goes haywire. So why are we talking about insomnia? Because insomnia actually has tentacles that reach into all sorts of other areas of a person's health. So it's a risk factor for cardiovascular disease, hypertension, diabetes, and so forth. And you can see that the relative risk goes up substantially if you have insomnia for these different health conditions. And the numbers a little bit smaller are the proportionate attributable risk. So if we could reduce insomnia, we could actually reduce the actual rates of cardiovascular disease, diabetes, type 2 diabetes, type 2 diabetes, hypertension, car accidents, and so on, and save the healthcare system a substantial amount. If we could reduce insomnia symptoms by about 5% from 23% down to 18%, we'd save around $350 million a year. So there's a significant impacts on health and our health economics if we can do a better job at managing insomnia. So with the Queen's group, we've just submitted and got accepted a model that really is talking about a step care model for insomnia treatment. And here's kind of how we see things now, where the vast majority of insomnia is managed by primary care practitioners and also community pharmacy. And what we would like to see is a change where people are aware of self-help approaches and using the self-help approaches, particularly first-line therapies, which are very much underused, no matter whether it's primary care or any other layer of the step care model. So this is really why Sleepwell was developed, as I mentioned, about 10 years ago or so, and it has two major objectives. One of them is to achieve better insomnia treatment outcomes with CBTI, first-line therapy for insomnia, and to reduce sleeping pill use and the related harms. And so over the last 10 years, those two objectives have not wavered. If you've ever gone to our website, it'll look like this when you arrive. And we've really increased the content of the website and made it bilingual over the last couple of years with Health Canada funding. And I just presented some data last week in Toronto and was looking at the use of the website from across the country. And actually, BC really stood out. It's about 53% higher in terms of monthly visits to our website than compared to across the country. So what would have been expected, and that was really interesting to see. When you're on the website, and it's really for you and your patients, and really for you to send your patients to help them with rethinking their overall approach to the management of insomnia and be able to do things more on their own because they've been using the resources and recommendations of the website. So the main reason people visit our website is for what they can get and learn about with CBTI. So these 4 tiles are all interactive. You click on the tiles to learn what is CBTI and then learn about CBTI as you dig a little bit deeper. And there are tools on the right side. There's a sleep diary. And I'm going to bring up a sleep diary or just mention a little bit later again. But if you haven't been using a sleep diary as a handout to your patients or recommend it to your patients to get it off of our website, I strongly encourage you to do that as an effective intervention for the treatment of insomnia. Using a sleep diary makes people more aware of their sleep patterns, and they can address those variations in their sleep patterns directly just from handing out a sleep diary. And we have a sleep calculator, so end of week you do calculations of your overall time to get to sleep, how long you're sleeping for, what your sleep efficiency is, and you can track that over time as part of a CBTI program. So there's a few different resources there. Another way to help people come to rethinking their approach to the management of insomnia and think about the long-term use of sleeping pills as potentially not for them is to look at some of the stories that we've been posting. So we have Faye's story and George's story in the 2 official languages, but they're on YouTube. So they're actually available when you want to look at closed captions in dozens and dozens of languages. I know there's very many languages spoken across BC, and so individuals can actually read their stories as they're listening to them in the language that they were presented in. We have other stories, some from healthcare providers, psychologists in Vancouver, and other stories from patients and other healthcare providers for you to look at and for patients to look at. And as I mentioned, it's bilingual, so everything that you see on the website can be seen in French as well. So back to CBTI. CBTI was originally developed with a therapist providing CBTI, and that is great if you can access it, but the vast majority of people with chronic insomnia don't have access to a therapist. So self-help approaches have been developed and have really ramped up over the last 15 years with great evidence to support them as an effective intervention. And then there's hybrid versions of these. The most important component of Sleepwell's website is what Sleepwell recommends. So if you go to the Sleepwell recommends page, it doesn't look exactly like this, but you'll see resources that people can access immediately. So even though CBTI itself feels like it's hard to access, it is hard to access if you're looking for therapist-based CBTI. It's not hard to access if you're looking for self-help approaches. So on the left are some recommended books. Sink into Sleep is a book that I basically go to and recommend for patients because of its workbook-like approach, written by Judith Davidson out of Queen's University, a sleep psychologist. And on the right, you'll see a few different digital options. The bottom left is from the US VA system. It's free to everybody and anybody. So if you have a patient who is looking for a digital option to go through a short program that they can control themselves, that's CBTI, they can use that as first go-to if they'd like. And our website will continue to be updated as different resources come along. Another handout that is an intervention in and of itself is the CBTI versus sleeping pills handout that's on our website. And at the meeting last week in Ontario, somebody came up to me to say, I give this to all of my patients. So instead of refilling prescriptions, you can refill a prescription and you can also give this as a handout and have a different conversation that your patient may be more ready to talk about when they come back and see you next, talking about CBTI. There is information about sleeping pills on the website, and there's a good number of people that go to this part of the website, although most people are going to the CBTI pages as well as the Sleepwell recommended pages. And so I just thought I would quickly verify what you heard from Aaron, which is how to help people come off sleeping pills who have been on them for months or years. And we have a Stop Sleeping Pills guide that helps people do that over a very slow period of time. So if your patient has started off here and is basically saying that they are ready to stop sleeping pills, you can just draw this for them and say, here's an overall approach. If they're on two different types of sleeping pills, you would obviously only have one graph or one line of decrease if they're on one, and really show them that it's a gradual plan overall that can take weeks or months to complete, depending on how long it will for each individual. And I often say, we're not taking something away. We're not trying to take away your insomnia treatment. We're trying to substitute it for a better treatment, a short-term treatment called cognitive behavioral therapy that has a long-term benefit on sleep, months and years. Studies have followed up the effectiveness of CBTI, and they're sustained for as long as the follow-up studies have been done, which is over 2 years now. And using these, you can work with your colleagues, you can work with your pharmacist to help the patient plan out their dose reduction overall. And so this could be filled out by you or filled out by the pharmacist. And the patient then fills out what actually happened and then go back to the pharmacist or yourself to suggest the next steps of the taper. Sometimes the tapers can take months and months, so it's better not to come up with a plan that has to be thrown into the garbage and restarted again. So it's better to do it in step-by-step format, which is this is suggesting. We get a lot of questions about how do you blend together CBTI and dose reduction or the gradual dose reduction, and really it's up to the patient. So it can be CBTI 6-week program here, so you can see there's 6 blocks. So this is an example program. Sometimes it's 4 blocks, sometimes it's 8 blocks, so it can vary. But it could be started before the dose reduction overall and support the individual to feel confident in going into the dose reduction, or during it, or near the end of it, or even after it. So people can come off of their sedative hypnotics without doing CBTI. They might change a few things about their sleep and daytime habits, though it's not necessarily full menu CBTI. And if their sleep starts to deteriorate, they can do a trial of CBTI. So let's just quickly look at an evaluation that we did of the Sleepwell intervention and some resources that have come out of it that are available to you and your patients. So we did the Your Answers When Needing Sleep in New Brunswick randomized controlled trial, and it had 3 arms: the Sleepwell intervention, the Empower intervention, which was an effective set of 2 booklets that was studied in Montreal a few years ago and shown to reduce the use of benzodiazepines, and then a control group called the Treatment as Usual group, who had no intervention. And I want to make it really clear, people received these packages by mail upon completing the baseline assessment, and then nothing happened. Nothing at all happened. The only part of the intervention is receiving the booklets by mail. 6 months later, we assessed the patients again, so the 6-month follow-up, and I'll show you what we found. And I just want to make it clear, there was no other intervention. There was no training of physicians, no training of pharmacists. It was a direct to patient intervention, and the patients, based on the information they received in the booklets, were then engaging their physicians or pharmacists with interest in changing their overall approach to managing insomnia. So this is what the booklets package looked like from the outside, so to speak. We embedded 29 different behavior change techniques based on the behavior change wheel throughout the 3 resources here, the cover letter and the 2 booklets. And when you look inside, you can see it's interactive, take the quiz, and then showing information with illustrations about the dangers of sedative hypnotics and the vicious cycle and so forth. And then we have a story about Jerry, how to come off of sleeping pills and how that worked out, and a couple of other tools. So not all of the pages are there. And then how to get your sleep back. It introduces CBTI within the book and different resources patients can access. Some patients access the recommended book, which was Sink into Sleep, 20% in the study, and others found that the information in the booklet was sufficient for them to learn some new sleep-enhancing techniques. So here's the overall results: 565 individuals in the study itself. Most important information is probably that people on average were 72 years of age with an average of over 11 years of benzodiazepine or Z drug use, and about 31% of them had had a fall in the previous year. Bottom line number is 5.3. For every 5.3 Sleepwell packages mailed out, one person stopped sedative use by 6 months. Here's what the numbers actually look like. The bottom blocks, the darker blocks, are the stopping their benzodiazepine or Z drug without switching to any other sedative. So switches were not allowed. Only those who were considered to have stopped could not switch. So 26% of people who received the Sleepwell intervention had stopped within the 6 months, and also a good number with the Empower intervention, and significantly less with the treatment as usual. The upper blocks, the lighter blocks, are those who reduced their dose by at least 25% at the 6-month follow-up assessment. So you can see a really simple direct-to-patient intervention had a substantial improvement in sedative use, as in having so many patients come off of it or reduce their dose substantially, almost 50% with the Sleepwell intervention. This study was the first one to actually look at sleep outcomes and daytime functioning outcomes as well. And the only improvements were seen with the Sleepwell package. So CBTI technique use improved. Sleep onset was 27 minutes faster, which is better than the sleeping pills itself. And it didn't matter whether they stopped their sleeping pills or didn't stop their sleeping pills. Their sleep improved with the Sleepwell intervention. Sleep efficiency also improved substantially. Insomnia severity was reduced significantly, and daytime sleepiness was reduced statistically significantly as well. We were concerned with that many patients reducing or stopping sedative hypnotics. Would anxiety be worse or quality of life be worse? And in fact, it improved, although the difference was not significant. So let's just summarize with quick 3 slides on the overall takeaways. So for short-term insomnia, which really I think Aaron was talking about, when we use sedative hypnotics, we should also be thinking about what can we do for the patient to help overcome their insomnia without a need for thinking about long-term use of sedative hypnotics. So we shouldn't be just talking about sleep hygiene. We should be talking about the effective other interventions that apply for short-term insomnia, and that is stimulus control. So a lot of different resources that are based on CBTI will suggest in the short term insomnia treatment, stay up later than usual, go to bed only when sleepy, leave the bed if not sleeping, make sure you're getting up 7 days a week at the same time, and use a sleep diary. Add the sleep hygiene to it, and if needed, only if needed, think about a short course of sedatives. For chronic insomnia, recurrent insomnia, like really insomnia where the person has it coming back often or lives with it for more than a month, we really should be prioritizing CBTIs, sleep enhancing techniques. And we should be really thinking about what are we doing with sedatives? The person has chronic insomnia. Clearly, sedatives are not the answer to that. They're less effective overall, and that's why first-line therapy is CBTI. So for you, adopt and use effective techniques of CBTI in your practice. So hand out sleep diaries, talk about those issues that are, or those techniques that are related to stimulus control that I just mentioned, and learn a bit about time and bed restriction therapy as you learn a bit about CBTI, because stimulus control and time and bed restriction therapy are very effective components of CBTI, and maybe the only components that the vast majority of patients need as they're going through CBTI programs, or they may not even need to go into a program but get advice through you or some other means, including the Sleepwell websites and so on. De-emphasize the need for sleep medications and sleep hygiene, especially when we're talking about those with chronic insomnia or the very long-term use of sedative hypnotics. And share the load. Work with pharmacists, especially when it comes to the reduction of medications. On the right are recommended resources if you want to learn more about CBTI and deprescribing sedatives. So we have a program at True Queen CPD, which you can find out about when you visit the MySleepwell website. Just click on the clinicians page and you can learn more about that. And many of us who have kind of come into the CBTI world have said reading sink into sleep has really made us comfortable with advising on CBTI and some of its sleep enhancing techniques. So once you're done the book, you can give it to a patient for to go forward. And if the only thing that you do differently going forward from here is to help patients get access to mysleepwell.ca and give them encouragement to do things on their own, they could start with what we used in our Janssen-B randomized trial, which are now available to your patients on our resource center. Everything on the Sleepwell website is free. None of it is making money, but we do have a cost recovery model just for the booklets because the booklets are quite expensive. So they're $5 per booklet for when patients buy them individually. We can have PDFs shared if there's a local printer involved, and they're going to be distributed through printing to your patients and so on. And you can also buy very large quantities through Vistaprint, and we have nothing to do with that. But if your individual patients want the booklets, they can order it and they can have it shipped to them for $5 a booklet plus shipping. So that's everything I plan to share with you, and I'm happy to take questions if we have time.
Thanks, David. That was amazing. It's nice to see we have some complimentary messages, and your CBTI stuff adds a level of tools that people can use that our information just doesn't. I've gone through your website and found it incredibly easy to use and intuitive. We have had some questions. One of them was, question is, many patients are resistant to wean off or even reduce the dose of Zopiclone since they've been on it for decades or 20 years without any perceived harm. Any recommendations about how to approach this conversation and coach the patient? Most of these patients are over the age of 80 and on doses of Zopiclone above the ceiling.
So I think we've had really good success with that. And that's probably the most common yes, but that we hear. So we hear a lot of yes, buts as we go through this process. And there's a variety of things that I think. One is we're not expecting people to be ready to make the change all at once. So
Mm-hmm.
a single conversation is often frustrating as opposed to productive. And so the approach that we recommend is to take your expectations way down and let other tools do the talking for you and have patients come back to you who are ready to make those kind of changes. And then you can build up your own repertoire of success stories. And one success story can build on another success story and so forth through your own kind of experience. So the resources that I mentioned, the CBTI versus sleeping pills handout, is one very simple handout that if you hand it out to individuals who are getting refills through you, you can have a different conversation the next time you see them. But one of the most important things that we say is that there was a time and a place for this medication to be safe and effective for you.
Mm-hmm.
As we get older, the safety concerns go up a bit and the effectiveness doesn't go up. It actually can go down. But there is an alternative that is safer and more effective. And so we would like to introduce you to something that's actually a better choice for you now and think about gradually lowering the dose. And I know you haven't had adverse effects with it, but we also know that the person that didn't fall yet and did fall didn't have any adverse effects until they had a fall.
Sure.
And you may not recognize just how much this medication is affecting your cognition until you reduce the dose substantially and come off of it. And the video by both George and Faye speaks directly to how much their lives changed when they came off the medications. So with this answer, I'm trying to show you the different ways we've built some tools that'll support you so you don't have to do all the talking and convincing, but the tools can support your patient rethinking their approach, becoming ambivalent, a little bit of motivational interviewing techniques get thrown into the mix. And
Mm-hmm.
ultimately, you may have success with some patients. I'm not saying you'll have success with all patients.
Sure.
We're doing some research on who you may have more success with and who you may have less success with based on personality features.
Excellent. I've noticed this, like those two videos on your website are fantastic, and I recommend people watching them and sharing them with their patients. The real patient videos are so compelling. One of our colleagues, Dr. Tom Perry, has a whole suite of patient recordings about all sorts of things from deprescribing to experiencing harm. And even for clinicians that learned about these things in school, when you actually hear a patient, how they felt, or you see what the adverse effect looks like, it completely changes. One of the questions was some of patients use Zopiclone to help them get to sleep, but some of them use it in the middle of the night to help them get back to sleep. And do you have any
Yeah.
comments on that or?
That comes up where patients have told me I take my 7.5 milligrams and then I go to the bathroom at 2 or 3 in the morning and I always take 3.75 and that gets me right back to sleep. Like that is their story.
Mhm.
And when we think about onset of effects and so forth, there's a bit of a chuckle that goes along with that. The concern is a magnification of the negative effects the next day. So any activities that you're doing are going to be even that much more impaired. And people have become so used to their morning feelings, they don't know what it's like to not have those medications. So it's a dramatic change for those individuals who say, "Oh, wow, I did a CBTI program. I went through the toughest part, which was consolidating my sleep into a short time frame of my sleep window that I went to bed at 12:30 and getting up at 6:30. So only being in bed for 6 hours was what I was allowed to do for part of my CBTI program. And that takes away the frustration of being in bed,
Mm.
not being able to sleep. And that's what perpetuates it. And so people don't have a clue to do that kind of thing. They go to bed early going, tonight's going to be the night. I'm going to get the best sleep and I'm going to give myself the best chance. But what happens is you lie in bed going, it better be coming. I need this sleep. I haven't slept well for the last 3, 4 nights. Oh my goodness, I really need a great sleep. And it only perpetuates the whole cycle, the hyperarousal and so forth.
Sure.
So
Yeah,
CBTI is designed to directly address the causes that are perpetuating the sleep, which are no longer the precipitating factors, the lost job or the lost relationship from years and years ago. It's
mhm,
not now hyperarousal and cognitive factors. And so CBTI actually helps to directly affect those through its behavioral techniques and then, if necessary, the cognitive techniques. So it's just jumping in, like let's give this a try. And once you give it
sure.
a try, you'll have a few patients that say, I can't believe that it was as straightforward as that.
That's good to hear. We've got a few minutes, so this is going to be the rapid fire question session. First one, how long do withdrawal symptoms last when deprescribing meds?
So with our yawn study, we looked at that. We had 10 people out of 140 who stopped their benzodiazepines and Z drugs who classified themselves as having it for longer than 4 weeks. These are
Mhm,
people who took it for 11 years. So the
mhm.
vast majority of people can come off long-term benzodiazepines and Z drugs without the scary stuff that we've all heard about over the years.
There's two questions that are related, so I'll combine them. One adds the element of smart devices and watches that track sleep, and people get worried because the devices say, "Oh, they're waking up several times through the night," and someone else asks, "What is normal sleep?" Because there may be a misperception of normal sleep doesn't include multiple wakings through the night. So can you comment on that?
Normal sleep does include multiple wakings through the night,
Yeah,
and as we get older, those awakenings happen more obviously to us all. So we can normalize as opposed to medicalize or pathologize those. And when we try to adjust the awakenings that are 2 hours long, that's where CBTI can be quite helpful. But at the same time, the education of it's quite normal to have to get up in the middle of the night and have some difficulty falling back asleep. But it doesn't mean you need a sleeping pill because sleeping pills may actually be causing more harm than helping the underlying issues that are associated with insomnia and the comorbidities. So we're not necessarily getting what we think we're getting from using
sure.
the sleeping pills.
And that whole issue of next day impairment, there's a great video of Dr. Perry's video. He asked this woman who was on amitriptyline and he said, "How do you perceive an insomnia med that when you take it, it helps you sleep, and when you get up in the morning, the effects are gone?" And she said, "Yes, that's exactly what I perceive." This woman had been seen by a pharmacist, had a very engaged prescriber, and yet that perception still persisted or wasn't addressed.
We don't do a good job. Like
Hmm.
across pharmacists and across physicians, we don't do a good job because we don't actually know how to do this well. We say to the patient who's starting on some sort of sedative, and beware of driving or doing other things the next day until you know how it affects you, not recognizing they cannot figure out how it affects them. So to be able to say your ability to drive in the morning may be impaired, but you'll be able to figure that out, that's not true. You can't
Mm,
expect them to figure it out. It's like asking somebody who has zero point zero 0.05, 0.07, 0.08, 0.09 alcohol, do you think that you can drive? I think I'm quite sure I can drive, but we know that the risk is incrementally increased as the impairment goes up. So it is a bit of a doubling or tripling or quadrupling of the risk based on the observational data that we have.
interesting. Okay, I think I'll just wrap up. David, thank you so much for participating